Hello, everyone, and welcome to today's webinar session, which is the first of two sessions planned to share the key findings and insights from the British Columbia edition of the Canadian Atlas of Palliative Care. And as I always like to say at the beginning of these sessions, please don't be shy. Introduce yourselves in the chat at the bottom of the screen. We'd love to know who you are and where you're from. That would be great. Thank you. Next slide. Before we get into the contents of today's webinar, I want to take an opportunity to acknowledge the land in which I am presenting from, which happens to be the city of Ottawa, is the traditional unceded and unsurrendered territory of the Algonquin Anishinaabe people. The Algonquin peoples have lived on this land since time immemorial, and I'd like to acknowledge the historical oppression of lands, of cultures, and the original peoples in what we now know as Canada, and believe wholeheartedly that the work that we all do in palliative care can contribute to the healing and decolonizing journey that we all share together. We're very grateful to have the opportunity to be present in this territory. So today's presentation is part of the Palliative Care Echo Project, which is a national multi-year initiative aimed at cultivating communities of practice and supporting continuing professional development among healthcare providers across Canada who care for patients with life-limiting conditions. The Palliative Care Echo Project is led by Pallium Canada and its hub partners from across the country. The project delivers a continuous learning journey for healthcare providers to build local capacity to provide a palliative care approach to patients and their families. This project is designed to create virtual communities of learners in palliative care by bringing together local healthcare providers and community leaders with regional, provincial, or even territorial and national subject matter experts for, again, continuous learning, deep dive discussions, national presentations such as this one, and interactive case-based discussions. And the Palliative Care Echo Project is made possible thanks to a financial contribution from Health Canada, and the content and views expressed throughout today's presentation do not necessarily represent the views of Health Canada. So I think it's also important to understand that the Palliative Care Echo Project certainly is not a replacement for foundational training on the palliative care approach through programs such as Pallium's LEAP courses. If you haven't taken a LEAP course to acquire those, the knowledge, the skills, and the confidence to provide earlier, more effective, more compassionate palliative care to patients and their families, such as the one that you see here on the screen, which happens to be LEAP Core, I would encourage you to do so, and you can visit pallium.ca to get more information about these types of courses. This particular course, LEAP Core, is accredited by the College of Family Physicians of Canada for 24 main pro credits for the online and hybrid versions, and 28 main pro credits for the in-class version. Okay, so joining me in today's presentation is Dr. Leonie Herx. Leonie is a palliative care medicine specialist practicing in the province of Alberta, is a clinical professor in the Cummings School of Medicine at the University of Calgary. She's also a research associate with us here at Pallium for the Canadian Atlas of Palliative Care Project, and is a senior scientific director of the Palliative Institute, Covenant Health. So it's good to see you again, Leonie. A warm welcome to you. And on the next slide, in terms of just some reminders, again, very warm welcome to all of you. We're really excited about this presentation today because it's the first of its kind to present, this atlas. So just in terms of some housekeeping items, your microphones have been muted. Obviously, that doesn't mean that we don't want to hear from you. So we do want to hear your thoughts and your questions throughout the webinar. And you can express yourself by putting your comments in the chat function at the bottom of your screen. And when you do this, you're ultimately contributing to the overall knowledge that's going to be shared over the next 60 or so minutes. So thank you in advance for doing so. Please also remember not to disclose any personal health information during the session. Briefly, in terms of conflict of interest, as mentioned earlier, the Palliative Care Echo Project is funded through a contribution agreement from Health Canada, which of course includes these types of sessions. Pallium also derives funding from the sale of its LEAP courseware and its Pallium Palliative Care Pocketbook. But in terms of conflicts, I'm an employee of Pallium Canada. Leonie is compensated for her role as our research scientist associated with the Palliative Care Echo Project. Other than this, I don't believe there are any other conflicts to declare. So with that behind us here, We're going to move forward now with the highlight of today's presentation, which of course is the BC Atlas. Next slide. So again, thank you for joining us today. Again, this is a momentous occasion for all of us on the call today because you're going to be privy to the launch of the British Columbia edition of the Palliative Care Atlas. It's really a privilege to be with all of you here today, colleagues, partners, stakeholders. I know you're all committed to strengthening palliative care, not just in British Columbia, but across this country. And this atlas really is part of a larger national initiative to better understand and visualize the palliative care landscape in each province and territory. And our goal is to support planning, policy, education, system improvements, really grounded in evidence and informed by the voices of those delivering and coordinating the care on the ground. So today's session's really going to walk you through the key findings from the BC Atlas and offer you insights into the process, that exists behind this atlas, and share some of the information that ultimately can be used to inform future work. Okay, so let's start with some overall aims here. The overall aims of the Canadian Atlas of Palliative Care, BC edition, are really to raise awareness of the current state of palliative care in this province. It also aims to improve equitable and timely access to palliative care, to identify and spread excellence, to guide and inform, as I mentioned before, policy making, planning, capacity building, and the provision of palliative care, and to enhance the overall quality of palliative care in jurisdictions across the province. The Canadian Atlas of Palliative Care will describe, as you'll see, the current state of palliative care across several domains and indicators in the province, and ultimately across Canada, federally, provincially, and territorially, and at regional levels. It'll identify and highlight areas of strengths and successes with the goal of spreading and scaling these initiatives, but it will also identify opportunities for improvement. It'll serve to raise the collective awareness of the status of palliative care for populations that require special attention, including children, 2S LGBTQI populations, incarcerated persons, recent immigrants, refugees, homeless, and marginally housed, and will inform ongoing health system changes and improvements in palliative care to ensure equitable and timely access for all who need it. Actually, I'd just like to extend my heartfelt thanks to the core research team and the authors behind this edition of the Atlas. This work would not have been possible without their dedication, the rigor, the deep commitment to advancing palliative care in this country. They brought together expertise from clinical practice, research, education, system leadership. And I think it really shows in the quality and the thoughtfulness of the work. From the earliest stages of design and methodology to the interviews and the data analysis and the writing and the validation, this team did pour an incredible amount of time and energy and care into every single step. So on behalf of Pallium and everyone who will benefit from this resource, a very big thank you to all of these individuals for their leadership and insights and the tireless work in bringing this atlas to life. So thank you for that. I would also like to begin by expressing our sincere gratitude to the funders who made the British Columbia edition of the Palliative Care Atlas possible. Their generous support not only enabled the development of this resource, but also reinforced the importance of investing in data and evidence to strengthen palliative care across the province. So thanks to their contribution and patience, we've now have a detailed and accessible snapshot of palliative care capacity, gaps, opportunities that are unique to British Columbia, insights that will ultimately help guide decision-making and planning and future investments. So this project, I think, is a true example of what can be achieved when funders, health system leaders, and community stakeholders come together with a shared vision for compassionate, high-quality palliative care. So again, on behalf of the entire team at Pallium and our partners across the palliative care community, thank you to all of these funders for their commitment to ensuring that people in BC receive the care that they need when and where they need it. And a particular shout out to the Sovereign Order of St. John's Knights Hospitaller, Vancouver Commandery, who joined us as our lead funder very early on in the project, have been incredible supporters and have had incredible levels of patience as this It was a very involved project that took quite a bit of time to get to where we are. So big thank you to them, of course, all of the other ones as well, YP Young, Conconi, Ford Family, St. Mary's Health Foundation, New Westminster, and the Hamber Foundation. We're also deeply grateful to the many provincial and regional stakeholders across the province that you see on the screen here who contributed their leadership and their time and insights to this project. And I really do want to give a special shout out to the BC Centre for Palliative Care, who was our lead provincial partner for this atlas. Frankly put, this atlas wouldn't exist if it wasn't for their involvement. So thank you, BC Centre. You're absolutely incredible group to work with. Really the firsthand knowledge, of the challenges and the innovations in delivering palliative care that was provided by all of these organizations really was instrumental in grounding this atlas in the lived realities of patients, of families, and care teams across the province. Again, not possible to have this atlas without their collaboration, whether that was through interviews or data sharing and strategic guidance. Their input really helped ensure that the atlas is both accurate but also action oriented. Their commitment to improving palliative care access and quality in their province is evident, and their leadership continues to set an example for others across the country. So we really hold BC up as a shining example of how to get an atlas done. So, and I think I can speak for all of them when I say that we don't see this atlas as an end, but really as a starting point. And we look forward to continuing this important work as we build a stronger, more compassionate system of care for all British Columbians. So the precursor to the work of the BC Atlas, believe it or not, began back in 2019 in response to the federal government's framework on palliative care in Canada. And that framework called for better ways to assess and monitor palliative care across the country. And that was the impetus for Pallium to launch the development of the Canadian Atlas of Palliative Care. And we drew inspiration and guidance from the international atlases that have been developed by the University of Navarra in Spain. And to get started, we brought together a research team made up of leaders in palliative care and primary care, researchers, clinicians, educators from across multiple provinces and organizations, including representation from the University of Navarra itself. Our work began with 2 pilot regions in Ontario and grew to include the development of 3 provincial atlases, one for, of course, BC, Alberta, and Ontario. And our goal is ultimately to have 13 provincial and territorial editions, each with regional subsections and a federal level atlas summarizing the status of palliative care at a countrywide level. And that will allow for comparisons with other countries. So it's worth noting that this edition of the Canadian Atlas of Palliative Care does not reflect palliative care services and programs of First Nations, Inuit, or Métis peoples. Instead, and as we state in the Atlas with humility and in the spirit of reconciliation, Pallium is dedicated to collaborating in a distinct process led and developed by Indigenous peoples to describe palliative care across Turtle Island, provided by, with, and for Indigenous peoples. So we're going to start first with the domains and elements within the Atlas. So as you can see on this slide, the Atlas presents information across 9 domains, and within each domain are a number of elements. And these domains and elements are based on those used internationally, but have been adapted for the Canadian context. They were then tested through a pilot study involving 2 Ontario regions that included urban and rural geographies and demographics, and the experiences and the learnings from these pilots informed additional modifications to the process and the domains and the indicators and the protocol that we used in this provincial atlas. The different domains and indicators really do allow for comparisons across the regions and provide more detail given the large and varied geographies that that is British Columbia. So overall, the reporting of the results of indicators presented in the Atlas falls into a few different categories. Some indicators are relatively straightforward to identify and to measure. When we talk about the presence or the absence of a policy or a law, or presence of a palliative care unit or a hospice residence, these are reported as existing or not existing. In some cases, they exist, but partially, such as the coverage of palliative care medications or or supplies in a home setting. In these cases, we've reported them as partial. But some other indicators are actually quite challenging to measure accurately and across the whole province. The level of integration of palliative care across all hospital services and across all communities, frankly, wasn't feasible given the resources available and the availability of data and the significant variability that often exists across communities and regions. So for these, we had to really give a global judgment based on, the multi-source input that we received, and that's ultimately what we had to do. So to obtain the best possible representation of the status across all these different domains and indicators, and to reduce the risk of potential biases or inaccurate impressions of both informants and the researchers, this study has used a mixed methods, a multi-source and a multi-informant approach. So we developed consensus through multiple stakeholder iterative reviews, ensuring input from different perspectives, multiple information sources, including health system leaders and frontline clinicians. Once the identification of domains and indicators was finalized, we then obtained Research Ethics Board approval and established a collaborative partnership with our lead partner, the BC Centre for Palliative Care, as I mentioned earlier. Data collection began with the search for publicly available data involving searches on various websites and various reports. At the same time, we began recruiting participants in collaboration with the BC Centre and the regional health authorities. We developed standardized online surveys that were completed by the key informants from the province, from within the regions, and from within the schools of nursing and medicine. We then conducted interviews with other key informants to confirm or to clarify and expand on the responses that we received in the survey. Focus groups were then held from individuals within the regions and sectors to comment on the information that was collected publicly and from the survey and from the interviews. And then a final verification of the results was undertaken with provincial and regional leaders. So as you can appreciate, given this methodology, it's no wonder why it takes so long for these atlases to be developed. But I do want to take just a moment here to clarify Pallium's role in this methodology and ultimately in the development of this atlas. Pallium's responsibility was to ask the questions, gather the data, and report on what we heard, not to make recommendations or to interpret findings through a particular lens or filter the information in any way. This atlas is intended to serve as a reflection of what was shared with us by stakeholders across the province. It's their voices, their insights, and their experiences that form the foundation of this work. Our goal throughout has been to provide a clear, evidence-informed snapshot of the current palliative care landscape. So in short, we've approached this work as I guess you would say facilitators and stewards of the information, really committed to ensuring that the data remains accurate, transparent, and grounded in what we have heard directly from those working in and affected by the system. So the atlas itself is divided into two parts. The first part reports at a provincial level, and the second part at a regional level. And then the regional part is then further divided into 5 subsections, each one corresponding to one of the 5 regional health authorities in British Columbia. Information within the atlas is shared in a few different ways. We have data that's presented on maps that will present different shades of blue based on levels of presence or availability of services or resources, and an example of which you see on the right-hand side of the slide here with respect to access to specialist palliative care. Data is also presented through dashboards where the extent to which a service or a resource is available is indicated through those colored circles. These circles can be accompanied by a letter V that really indicates a degree of variability. And then finally, you see a little megaphone icon that is shown when we want to highlight an innovative program or a strategy. So the other thing too is the atlas also has a comprehensive data dictionary that provides more information on specific terms, definitions, and standards for the the benchmarking of palliative care used in the atlas. So before we get into the actual data itself, I want to take a moment to explain one of the formats that we've used to present the Atlas data. It's something called a story map, which is developed using something called ArcGIS technology, which is a geodemographic software package. A story map is it's an interactive web-based tool that combines maps with narrative text, images, and multimedia content, all designed to tell a story, essentially. It's a powerful way to present complex information in a way that's easy to navigate and is quite visually engaging. So for this atlas, this format allows users to explore palliative care data and insights by region while also learning about the context and the stories behind the numbers. So it makes the data feel more alive and relevant, something users can interact with rather than just read. So in addition to a static PDF report, the story map really gives us a dynamic digital resource that we can continue to update and expand over time. And on the next slide, you see just what one of those looks like. And again, this is not an interactive presentation, but you would be able to put your cursor over that map and really expand and go deep into any of those colored regions. So certainly would encourage you to explore that in the atlas, and we'll provide you that information and the links to that in just a moment. And then before I hand things over to Leonie, I'm just going to kick things off with some key findings. But before I dive into those, I want to take a moment to acknowledge the cover design of the BC edition of the Atlas. So I'm going to go a little deep on you here, but we really love the imagery that's been selected here, and I hope you folks do too. So these visual elements that were chosen, they were chosen intentionally to ultimately reflect of course, the natural beauty, the diversity, the regional character of British Columbia, from its coastal landscapes to its mountain ranges and its rich ecosystems. But the design also subtly nods to the interconnectedness of communities, of health systems, of care providers across the province, reminds us that palliative care is not just a clinical service, but a deeply human, community-rooted commitment. So our hopes is that the cover sets the tone for what lies inside, which is really a thoughtful, place-based look at palliative care in BC that honors both the data and the people behind it. So with that in mind, let's tuck into some of these key findings, and my colleague Leonie is going to go into these in more detail. But I think it's important to lead with the fact that BC has a vibrant and a very well-developed palliative care system with high levels of access in most regions to specialist level palliative care services in both hospital and community settings. However, in rural and remote communities, they continue to face significant barriers, struggling with both limited service availability and challenges in recruiting specialized professionals, leaving many without timely specialized care. The other point is the BC Centre certainly plays a crucial role in advancing palliative care. The BC Centre has supported best practices. It fosters collaboration, promotes integrated care models across the province. Its initiatives, including the Compassionate Communities Movement and their LTC collaborative, are empowering communities and healthcare providers with the tools and supports needed to improve palliative care delivery. That was certainly a big key finding. Thirdly, you look at hospitals. Most medium to large hospitals in BC have access to specialist palliative care teams, ensuring access ultimately to consultant expertise. However, the integration of palliative care across various hospital inpatient and outpatient services is minimal to low overall, especially for non-cancer services. Better integration of palliative care within cancer and non-cancer services is needed to improve care. All physicians in the province, within hospitals and communities, have access to a provincial on-call palliative care physician telephone consultation service whenever necessary, certainly a high point. And this really is a vital resource, but further integration into everyday patient care is crucial to improve overall palliative care delivery. Across the province, community-based palliative care is strong, especially in medium to larger urban centers. These areas benefit from home-based care services, hospice care, and strong community support systems. However, some rural and remote regions have less than 10% of the coverage they need to access specialist palliative care clinicians. So in these regions, access is largely virtual, and in many regions, after-hour support relies on that provincial physician-led on-call line. Overall, there's an adequate number of palliative care unit beds for the province relative to the population size. However, two regions were found to have inadequate PCU beds for different reasons. One region has no PCU beds, and in another region, these beds are primarily designated for use by palliative care rather than being dedicated to palliative care. So designated beds may not be available for patients with palliative care needs when admission is needed, and staff may not have adequate expertise in palliative care. The number of hospice beds, though, in the province is largely adequate when calculated using a conservative measure of the minimum recommended numbers. But when combined with PCU beds for a total number of inpatient palliative care beds available, the number is inadequate and more are needed to meet rising population needs, especially with an aging demographic. BC, we must say and note, it has a highly engaged palliative care community with over 120 compassionate community initiatives supported through a seed grant program through the BC Centre of Palliative Care and a strong volunteer network supporting palliative care at the grassroots level. Volunteers, caregivers, and hospice programs serve as vital hubs of support, strengthening local networks of care and providing essential emotional, social, and practical assistance to individuals and families. So there you have it at a 40,000-foot level, whetting your appetite with some key findings. With that, I am now going to pass the microphone over to my colleague Leonie, who will take you through even more information contained in the atlas. Leonie.
Thanks, Jeff. So as Jeff well described, we have two sections to the atlas. The first is results that are reported at a provincial level using those standardized domains and indicators or elements that Jeff reviewed with us. And then the second section goes into the regional level and really digs in at a deeper level in terms of the amount of details that we can capture and report on with respect to those same standardized domains and indicators. There are, of course, 5 regional health authorities in BC. So in that section, you'll see full reports of all 5 regions. So of course, we won't have time to go into all of that detail today. I have about 15 minutes or so to walk you through some of the key findings. And so I'm going to focus our time today on the provincial level data. And I'll show you at the very end an additional map that we provide at the regional level, just so you can get a sense. But really what we hope you'll do after today is go in and dig into the atlas at your leisure, take a look at the interactive story map, and really get a better understanding of all that it has to offer and how it might help you in your local areas to think about priorities for improving palliative care, scale and spread, and opportunities. Next slide, please. So the first section of domain that we look at is demographics. This is just one of the tables that we include in our standardized demographics, and the map just shows the different 5 regional health authorities within the province. So you can have a look in more detail, but we report on population size as well as broken down by region, as you can see here. As well as population density, which is also mapped in a nice colored map. You can really see in BC here with the population density differences, as you would expect, that you go from a very rural, remote region like Northern Health, which has 0.5 people per square kilometer, to something like Fraser Health, which has an average of 125 people per square kilometer. So big regional differences in the geographies, which of course impact the types of services that can be delivered and what's going to function well in one region versus another. And so, as Jeff said, we don't speak to that, but we want you, of course, to take that into context when you're looking at the regional data. We also have age demographics as well as causes and numbers of deaths reported as well. So I'll move into the next domain where we really have good data to report on that looks at three different parameters, so policy, structures, and laws, formal strategies for palliative care, as well as funding for palliative care. And what we can see under the policy structures and laws is that there is no specific legislation in BC ensuring palliative care access. There is a law that looks at advanced care planning, but there is a provincial framework or policy related to palliative care. This is dating back now to 2013, and so an opportunity for, updating with respect to current population health needs from a palliative care perspective. And hopefully that will be one of the key takeaways from this would be to look at current needs from a palliative care policy delivery framework. There are formal strategies for home and community care, inpatient, outpatient services, and long-term care. They're embedded within that provincial framework, and as well as emergency services. And there's no specific policy or framework relating to rural and remote. And so that's another opportunity for improvement given the challenges that we identified. And of course, most of you live with respect to access to care in the rural and remote regions. With respect to government funding, there's partial funding for palliative home care, hospice residences, community hospice services, in-hospital medication supplies, and resources are fully funded. And out of hospital, of course, is more challenging. Next slide, please. Okay, so we'll dig into the next domain, which is services, and that's broken down by site of care. So starting with acute care, we looked at both the types and numbers of palliative care beds, inpatient beds within the province, and this includes palliative care units as well as hospice beds. So if you take a look at the PCUs, you can see that there are 10 palliative care units across the province that are dedicated to palliative care. And as Jeff described, dedicated means that it is protected for the use of palliative care. So admissions to palliative care are determined by the palliative care team, and they don't have to be negotiated, for example, through hospital operations or another service who might run the unit, such as oncology or medicine. And so those staff tend to focus their care on palliative care and have expertise around the specific needs of patients with palliative care needs. So you can see that there are 76 palliative care unit beds that are dedicated to palliative care. We did not capture the beds that are designated and may be used by palliative care as for the reasons described. So overall, there's about 50% of the dedicated palliative care beds needed in the province. Hospice beds, they're much more robust in number and location. There's just over about 320 hospice beds that can be found within specific hospice residences, as well as some hospice residence beds are in long-term care, as well as in some community hospitals. So overall, there's about 90% of the target number of beds needed. Again, this is using the Catalonia formula, which is a conservative estimate of population need for inpatient palliative care beds. So we determined that something within 10% of the projected target number would be deemed adequate. So that's why you see the 90%. It just recognizes that, things are being done really well, but that there's some room for improvement by giving the percentage. Overall, when you combine the total inpatient beds for both palliative care units and hospices, which is based on 10 beds per 100,000, you get about 80% of what the province needs based on the current population. Of course, with changing demographics of a population, multimorbidity and aging, the numbers of beds, of course, will change, and they could become inadequate, more inadequate more quickly. Next slide, please. So now we're looking at access to specialist palliative care teams within the hospital. So still looking at the acute care setting. And as Jeff described, at a provincial level, this was very challenging to represent. There's lots of variability, of course, across different regions and provinces with more on the ground teams who can see people in person within those larger urban centers. More rural and remote regions rely primarily on virtual teams. In the map on the right, you can see the color coding for kind of partial high to full for the different regions. And again, to dig into that in more detail, please see the regional sections. But you can see with a partial low designation that most of the Service is through virtual support. And if there's partial high, it may be that they have in-person support kind of daytime, or that they have people coming from time to time who travel to those communities to see people in person. The whole province, as Jeff described, does have access to this 24/7 on-call physician line that BC has set up, and that we really hope that that can be strengthened and maintained, because it is certainly an important source of access to many communities. Next slide, please. Also within the acute care lens, as Jeff described, if you look at how palliative care is integrated, so both within inpatient units, and these are non-palliative care units, as well as outpatient clinics across cancer and non-cancer, including cardiology, respirology, nephrology, and neurology. This refers to the teams themselves providing a palliative care approach for their own patients, as well as referring to specialist teams when more complex situations arise. So we're not talking about access to specialists on those units or in those clinics. It's really about that palliative approach, and then getting more help when that help is outside of that team's expertise. And this is, as Jeff said, really opportunity for growth and improvement across the province, with very little integration by and large in inpatient units and non-cancer outpatient clinics, and better integration, but still opportunity for improvement within the cancer setting. And again, to see the regions for more detail, there are some cancer centers that have more availability of a palliative approach than others. Um, and I wanted to just do a shout out to the BC Renal agency, because you'll see when you dig into the Atlas data, we have these context boxes underneath. Sorry, my computer's just asking me to reboot, which of course I don't want to do. So thank you for that. Where we really highlight either some specific context in that region or about that particular domain or indicator to better understand it, as well as um, things that are going really well that we want to really point out. So the BC Renal Agency has a provincial committee that's dedicated to palliative care, that's developed resources around palliative care, and an integrative palliative nephrology resource guide and a framework. Although it's a bit older, 2009, I think it's a real highlight and something that other provinces can learn from. Next slide, please. Next, we'll move on to, under the services domain, look at community. So in there, we look at access to specialist palliative care teams, as well as after hours access to those teams. And while there is significant variability in the different regions, and even with communities across regions, overall, there's reasonable access to, we would say, partial high across the province as a whole. As you can see, some regions have more robust, and interior had less availability of a specialist team, but take into account, of course, the geography in those regions. Next slide, please. The next indicator is palliative home care. So looking again is what the access to palliative home care is, as well as the after hours access. Many of the palliative home care services across BC are provided by generalist home care teams, not specifically specialized palliative home care teams. And overall, there's pretty good access during the daytime, and after hours access generally relies on virtual support. There are some regional teams who do have availability to go out and provide more local support, but by and large, it's virtual, and there's a 24/7 provincial nursing-led line that patients and families can access after hours as well. Okay, so now we'll dig into a little bit about primary care. Like in many places in the country, family doctors and nurse practitioners providing primary care are very overstretched. So it's no surprise that there's significant variability and overall lower levels of provision of palliative care by primary care teams. There's even fewer home visits and after hours 24/7 on-call coverage, which is mostly minimal to absence across most of the regions. While there's no formal standards or indicators for the provision of primary palliative care, there is training available, for example, through the BC Centre, some of their courses, and some of the Pallium courses as well. In rural and remote regions, there is no specific strategic plan to build primary palliative care capacity or indicators similar to the general primary care. But there again are courses available and funding for education on the palliative care approach. But the overall access to specialist palliative care teams in the rural and remote areas largely relies on traveling teams that come once in a while to different communities, as well as after hours virtual support. In the long-term care sector, um, there's overall fairly good access to specialist palliative care supports. And of course, variability across regions and across long-term care homes is definitely acknowledged. And there's overall some partial integration of a palliative care approach. This is an area that the BC Centre has been doing a lot of work on, and so I wanted to give a shout out to the BC Centre for the work they're doing on the SPA long-term care project and really supporting education for folks on the ground in long-term care. So even though there are no formal standards on training and indicators for providing palliative care and long-term care, there are good initiatives that are rolling out across the province. Next slide, please. With respect to hospice services, there are a large number of community hospice organizations, and our data may not have captured all of them. It was fairly difficult to obtain all of these organizations, but that a lot of community supports and practical resources and supports are being provided by community hospice organizations, as well as much of the grief and bereavement supports in the province. And with respect to paramedic emergency services, there is training for paramedics through the BC Emergency Health Services and funding for all paramedics who are hired by BC Emergency Health Services to take the LEAP paramedics course. The implementation of palliative care pathways across the different regions varies, but the education piece is, I think now over 50% of paramedics have been trained. Next slide, please. And I know I'm going through some of this very quickly. It's a lot of things to cover, and again, just welcome you to dig into it. Advanced care planning resources and programs are, very robust in British Columbia. Another shout out to the BC Centre, who's really provided education both for the public with respect to volunteer-led advanced care planning and healthcare professional serious illness conversation training for healthcare providers and students. Lots of resources available through community partner organizations as well for advanced care planning. And there is a palliative care competency framework for the province that the BC Centre has helped work on as well. Next slide, please. We don't specifically report on system performance, but we make reference in our data to what is being done at a provincial level. So you can see reference here that each regional health authority has a healthcare report card that's published multiple times a year, and you can access that through the various websites, governmental websites. Next slide, please. And I'm wrapping up in the next couple of minutes. So education was one of the most challenging areas to get information from. We had better luck with getting information from medical schools, mostly because there's one medical school, and the UBC has a division of palliative care that's associated with the medical school. So the academic division was able to give us much of the information about the education they provide in medical school. So as you know, there are 5 different campuses across BC, and all of the 4th-year medical students do get training in serious illness conversations. Nursing schools are, while there are 21 across the province, it was very hard for us to get information back from most of the nursing schools, and we don't have the same kind of level of organization with an academic division that allowed that easy facilitation for connecting with the right people. There are, I believe, 13 registered nursing programs, and just to highlight that 7 of those 13 also provide training for serious illness conversation for nurses in that domain. From a physician education perspective, as we say, we had more information. There are dedicated specialized training programs for both through the College of Family Physicians as well as the Royal College, which includes both adult and pediatric palliative medicine specialty training. And at a national level, there's nursing specialization in palliative care that nurses within British Columbia can tap into the CHPCN certification. Next slide, please. And within the education domain, just to make a note that there's more detail provided for those 5 campuses of the UBC medical schools. And if we had information at a nursing college level, really digging into what types of education is provided for which different types of residents who are training, who are rotating in palliative care, both in the classroom as well as clinical experiences. So please have a look there. Our second last domain is looking at professional activities, really like, is there a palliative care association or organization? Yes, the BC Centre for Palliative Care, as well as the BC Hospice Palliative Care Association. There's a good directory of services and resources through both of those provincial palliative care associations for continuing professional development. And the BC Centre of Palliative Care is hosting an annual symposium. There's lots of research going on primarily through the university's academic programs. And in the atlas, you'll see a snapshot of recent publications representing a very broad depth and breadth of palliative care research happening, um, across NAV care, for example, supporting community outreach programs, and more, medication-related studies happening, for example, through Dr. Pippa Hawley's work in Vancouver, and many palliative care quality improvement initiatives across the regions. And so some of those are highlighted. Next slide, please. And the focus population section has a dedicated attention paid to pediatrics, and then a review of some of the other key populations in a separate table. One thing to highlight for BC, as all of you know, is that Canuck Place Children's Hospice and their palliative care consult service at the BC Children's really provides incredible clinical support as well as research and quality improvement initiatives. The clinical support they provide is across the province 24/7 and even beyond BC to the Yukon. So there is 24/7 access to that specialist level palliative care team, and there's 2 hospice residences through in different regions. So those can be detailed what they each focus on in the regional maps, as well as education programs for pediatric palliative care. There's no formal strategy for pediatric palliative care, so perhaps another opportunity when a provincial plan is redeveloped. Next slide, please. These are the populations that we look at outside of pediatrics. And although there's no formal strategy for any of those and no provincial level programs or initiatives, you'll see in the context boxes and then with each of the regions, there are some really important and good work being done at regional levels for some of these specific populations, in particular homeless and marginally housed and recent immigrants and refugees. And please take a deep dive into those regional levels to look at some of the good work that could be scaled and spread, such as the PORT program on Vancouver Island. Next slide, please. This, I think, is our last slide, and then we'll be able to open it up to questions. As Jeff said, in this particular domain of community engagement, this is something that's really being done in a robust manner across British Columbia. There's a formal strategy relating to palliative care volunteers, many programs and initiatives, and training opportunities for volunteers, as well as for families and carers. And I just wanted to acknowledge the family caregivers of British Columbia, which really provides education, advocacy, and support for caregivers across the province, including a call center, one-on-one intervention, one-on-one and group-based interventions, education. So it's a really great resource that I just wanted to highlight. Compassionate community initiatives are happening across the province, and that's something that's been, there's seed grant funding that the BC Centre for Palliative Care has supported, and lots of NAV care initiatives. I think you're all probably familiar with Barb Pasut's work out of UBC Okanagan. So just lots of things happening that really are quite remarkable with the level of community engagement that we observed in the information we gathered across BC. I think that's it. Is there another slide? That's it. Oh, yes. So one more highlight again. So in each of the regions, all of these same domains and indicators are, as we said, described in a bit more level of detail that we could capture. But there's a couple of maps that are in addition that are not captured at the provincial level. So if we go to the next slide, you can see that what we're able to do is drill down a little more into the detail, especially around the inpatient palliative care beds. So where they're located, how many beds there are, what type of facility it is. And we did this both for hospices as well as palliative care units. So this is just an example of Fraser Health, so I won't spend any time looking at the actual information, but just to let you know that you can have a look at where the beds are, what type of beds are. You can scroll over the map on the interactive storyboard and they'll pull up more information about that particular site. So if you hover over each of the units, which are mapped as to where they are geographically, you'll then see their address and all the additional information about them. Next slide, please. And then this is just to show you how the hospices ones are done too. So lots more information that you can dig into. Okay, I think we're back to you, Jeff. Thank you.
Yeah, thanks. So there's a couple of questions, Leonie, and you and I will both take a shot at answering these. One of the questions I thought was a good one from Michelle talked about why the Interior Health Region has very limited services, right? And certainly, when we talk about that region, geographic barriers, workforce shortages, certainly are key components to that as well. But if I'm not mistaken, Leonie, in terms of PCU beds, was that something that fell victim to COVID?
Not in
Not
interior.
interior. Okay,
Yes, that
take that
was
back.
on island.
Island.
So
Yeah.
yeah, so I mean, we can't speak to why. We can say that there are no dedicated inpatient palliative care unit beds in interior. Good number of hospice beds, but that is an opportunity for improvement and it, as a tertiary cancer center in Kelowna, it would be good to have a look at the population lens and the estimate of the number of beds that would be needed. We do report on in each of the regional sections based on the Catalonia formula.
Cynthia asks about community education and support other than ACP. Are there other forms of education workshops and or compassionate communities awareness? So I would say certainly in terms of compassionate communities, the BC Centre compared to its counterparts across the country have a number of compassionate communities initiatives. You can also look at Pallium that has developed a number of resources to support compassionate communities, whether that's to start one, to measure the impact of compassionate communities. There was a number of resources there. In terms of other education support, I mean, I'm not going to talk to LEAP. I think we've mentioned that earlier on. Catherine Murray's Life and Death Matters, of course. We have Canadian Serious Illness Conversations training as well. Leonie, others that you want to highlight?
No, I think that covers it. We do highlight as many as we're aware of in the context boxes, so you can have a look at the regional level. There may be something highlighted that we haven't had time to summarize today.
Thank you for that question, Cynthia. Greg, hello. Good to see you on the call. Does Pallium have the number of clinicians who are elite core trained in our province? Not off the top of my head, but yes, that's a number we can easily access. And we're always looking to bolster those numbers, ultimately to do just what you're saying here is to increase the level of service and the number of individuals who have training on the palliative care approach, right, to build palliative care capacity. And look at that, just-in-time numbers from Holly have shared that we have about 100 clinicians who are elite core trained, Greg, in BC alone. And we're always looking to bolster those numbers for the very reason that you're mentioning here.
Elizabeth has a question about how often the atlas will be updated and what the process will
Ah,
look like for maintenance. A very good question.
it is a
I'm
good
giving that to
question.
you, Jeff.
Okay, yeah, no, great question. As I mentioned off the top, atlases can take quite a bit of time. We've learned a lot in the development of the BC Atlas, but the two other ones as well for Alberta and Ontario. We're looking realistically to have this atlas updated every 5 years. I mean, that is a realistic time frame based on other international atlases around the world. Their updating time frame, 5 years, is really what we're aiming for these atlases going forward. Great question.
There's another question here from Terry Weber that's asking about, is there any appetite for supporting more models of care to support patients and families who wish to die at home and sometimes need 24/7 nursing support for either respite or symptom management? And again, I think this is something that is good to dig into at the regional level and have a look at what's being done and what could be scaled and spread. There were some regions that were actually able to provide 24/7 palliative home care nursing support. And so it's an opportunity at a provincial level to look at how to leverage some of that information, and could that be put into potentially a new provincial framework with some standards around it. So not that we discovered through the atlas, but I think these are things that we want to look at in terms of next steps.
I'm just looking in the comments here.
Yeah, I
Thank you,
know. See
Aman,
if we've
for
missed anything.
yeah, thanks, Aman, for putting those resources in on the compassionate communities front. That's great. Any other questions that anyone has? Curious if you have learnings from your work with other provinces that you think would be helpful for BC's consideration. Sue, my answer to that is stay tuned. We are wrapping up the work. Well, Alberta's is essentially done. We're just doing some fine tuning on that atlas and completing the Ontario atlas. So that's going to be a very interesting subject for a future palliative care echo webinar session, is to do just that, to do that type of comparison. And Cynthia, even for Quebec, I hope so. Part of what we're aiming to do with these types of webinars is not just raise awareness of what we've done in the wonderful province of British Columbia, but hopefully entice other provinces to consider working with us in the development of other provincial atlases. More are underway for sure, especially out in the Atlantic. But we would love to work with the province of Quebec. So fingers are crossed there. All right, in terms of next steps, if you do want to, get your hands on this atlas, pallium.ca/BC Atlas. Again, pallium.ca/BC Atlas. Visit that and you will get access to the interactive story map, and you'll be able to poke around and really get into a lot of great information there. Obviously, what we really hope to come out of this atlas is for us to identify those opportunities, or for the province to identify the opportunities and to use this atlas as a tool to inform planning, policy, and funding decisions. We have another information webinar, a repeat performance of this. If you think others would benefit from this presentation, there is one being held on June 5th from 12 to 1 Pacific time. So please spread the word. We'll leave it at that. Thank you so much for joining us today. Very much appreciate it. Thank you, Leonie. It was great to co-present with you today. And thank you all for your questions and your input. Very much look forward to talking with you again real soon. Thank you for your support. Take care, everyone.